Hi, everybody. Welcome to VBF Facebook Live, October 2019, fresh off the heels of our conference in California, which was amazing, let me say. Yeah. This month's guest is Dr. Beth Drolet. She is the chairman at the University of Wisconsin for the Department of Dermatology. Yep. And she has been in the field of vascular anomalies for 25 years. 20?
Probably 25.
25 years. So any of you who are on, I see there's 5 of you on. Can you just text so I can see a thumbs up so that I know that you can hear us and see us? This is, we always kind of do a little check. Mm-hmm. I see there's 6 people on, but I'm not seeing any texting. So if you can text me, and oh, I see a thumbs up. So let me see some texting. Oh, here we are. So we're live right here. And there's one comment coming in. Okay, I'm going to allow. Okay, good morning from Rebecca. So I might have to use it on here because I don't know why I'm not seeing the questions. So good morning, Sarah. Good morning, Rebecca. Good morning, Erin. Oh, you're here at the conference. That's right. Hello, ladies. And Dr. Drolet is here for 45 minutes because she's got to get a flight back home.
That's right.
So you can start asking your questions about vascular birthmarks. We had so many wonderful presentations yesterday. So hi, Helena. You can hear us? Okay, great. Thank you. You can hear us and you can see us. Okay, great. So go ahead because we only have 45 minutes today instead of a full hour. Hi, everyone. Okay, follow up with Dr. Drolet. So see, she has your email and your direct link there. Thank you so much, April. April's on for VBF. So I'm not seeing the questions, and I don't know why on the screen, but I've got them on my phone. So that's all that matters. Okay, our daughter has a VM and made so many connections. So grateful for you all. And this is for the conference. That's great. Hi, Mahela. She is from Croatia, I believe. Boban and she's watching. So any questions you have for Dr. Drolet, you just takes a minute. We have 14 people on now. Okay. So we're happy to start answering your questions. Hi, Marge. April says, hi, Dr. Linden. Hi, Dr. Drolet.
Hello.
Mario Padav. Hello, Mario. Send us your questions. Let us know where you're from. Rebecca wants to know, Dr. Drolet, are there any new treatments or breakthroughs that you've seen?
Well, one of the things that our research works on is trying to find the cause of different types of vascular birthmarks and vascular malformations. And actually, in the last several years, our lab, as well as many labs around the country, have found genetic causes for vascular birthmarks. And we're really excited about that because that opens up the door for medical, or what we call pharmacologic intervention or treatments, either in the form of pills or creams. Really something we've not thought of in the past or really fully explored. So I think that's going to be the next big wave over the next 5 to 10 years.
And I heard at the controversies meeting in New York that someone made the statement that we've actually found a gene for every vascular anomaly except for the infantile hemangioma. Do you know if that's true?
Yeah. So one of the things that we do is we have a study where we take samples from different kinds of birthmarks, including hemangiomas, vascular birthmarks, from 20 sites around the country. And when we test those birthmarks, various birthmarks, venous malformations, lymphatic malformations, infantile hemangioma, about 80% of the time we'll find a gene that we call pathogenic, or a gene that we believe is causing the overgrowth of the blood vessels. There's still 19 to 20% of the time that we don't find it. It could be that we don't have the right sample, or we're not testing exactly the right genes. But the interesting thing is the one scenario is really the infantile hemangioma we haven't yet identified, and that's probably the type of birthmark we've been working on the longest. And so it's sort of been the hardest nut to crack. But out of the vascular anomalies, something that the malformations, I do believe that every one of them is caused by a change in the DNA that promotes vascular cells growing and getting larger, but not yet for hemangiomas.
But this is so wonderful because the parents blame themselves. You know, they're like, what did I do? Could I have done something? So nobody can do anything to prevent this.
That's right.
Helena wants to know, is it true that patients with blue rubber bleb nevus syndrome can have more lesions to form later in life?
Yes, that is absolutely true. And that's such a great question because for a long time, we as doctors and especially as the specialists in vascular anomalies, really taught that you're born with a vascular malformation. It shouldn't get bigger. It shouldn't change. You shouldn't get more. And now the genetics is really proving that a little bit wrong. And so certainly those of us that have been doing this for a long time, if you see a baby with a vascular birthmark or a vascular malformation, and 30 years later, it does look a lot bigger. It's slow. It happens over years, but there's no question that there's progression. And particularly in the blue rubber bleb syndrome, the mutations that cause that syndrome are what we call highly activating. And so they really grow a lot of new blood vessels. And that's why in that particular case of the blue rubber bleb, we do see new lesions. And honestly, for years, we've always seen them and we just thought, oh, you know, must have been there. Maybe mom didn't notice it. And, you know, but now with the genetics can actually kind of explain that can happen.
Okay, so we have a lot of questions coming in. So Mary from Ireland says hello. She has a 4-year-old son. He has an extensive port wine stain on his left leg. It is already 2 centimeters longer than the other leg. Is there any way of saying how much longer it'll be when he's fully grown? What treatments could help stunt the growth of these legs?
So as you notice, Mary, many times, especially on the arms and legs, when we have a vascular birthmark, not only do the blood vessels grow more, but the muscle and the fat and the bone can grow more. And that's something that we know is probably related to the genetic changes. So again, if you have a change in your DNA that's telling your cells to grow just a little bit bigger, that leg that has that change in the DNA will likely get a little bit bigger. Right now, I think a lot of the rate of change depends on the mutation that your child has in that affected leg. So it might be interesting to see if your doctors in Ireland can have some of that testing done, because that may help in prognosis. We're still at the point where we're discovering what this gene means and what that what the gene change correlates to the biologic outcome or the amount of growth. So I think it'd be interesting to do some genetic testing. We do have really a great procedure, which a lot of kids undergo, where they ablate the growth plate, and that's usually done when the kids are quite a bit older, and only done if there's a certain difference between one leg or another. So that actually is a really fantastic treatment. And so the main thing to remember, Mary, is to continue to monitor those changes on a yearly basis, so that the doctors can estimate what's the best time to stop the growth in the leg that's a little bit bigger, so that the other one can catch up. Usually it's done around puberty, but it depends a little bit. So right now, I think it's a watch and see. Consider genetic testing. Watch the leg lengths or the scanograms yearly or every other year if your son is 4. And then I am hopeful in the next 5 years, we will have medications. Now that we know the genes and we find the gene, maybe there would be a medication that could help stop that growth. We have to always balance the medication with safety and making sure that it's not going to do damage on other parts of the body that where that protein is needed. But I think your son's cases are probably going to be treated with medication in the next 5 to 10 years.
And by the way, Dr. Drolet was one of the speakers at our VBF conference this year, and we were very thankful for you to be there and on one of our clinic teams. So Mario Padov says, is it possible to completely cure a venous malformation of the tongue? And I think he's written in before and might have some bleeding and some issues.
Yeah, I would say with the technology that we have now, it's probably not possible to completely cure the malformations, probably of any type, but particularly the venous and the lymphatic, I think, give us the most trouble. They're very hard for our surgeons to see where they start and stop when they go in and try to excise, and sometimes we'll use laser surgery and the laser may not just get deep enough. So at this juncture, I think it is mostly controlling the symptoms, the bleeding, the pain, the size of the tongue, but not yet a cure, unfortunately.
And James Garvin said it was so true to hear about the genetic thing because he blamed himself for so long. So that's how important it is when we do this. Jean Susher says, hello, Dr. Drolet.
Hi, Jean.
From Mequon?
Yes, I know, Miss Jean.
So this is what happens to you when we were sharing that you were going to be on. A lot of your patients were posting. Rebecca Struckfuss says, what are some of the roadblocks you feel like for hitting in treatment studies, and in what direction do you feel the solutions are, and how can we help families?
Yeah, that's such a great question, Rebecca. So, you know, it's a really interesting thing because the science and the genetic discovery has outpaced our ability to do studies. And so we know the genes, we actually can put the gene into a computer, we can figure out the drugs, we have the science to make the medications. But what we don't have is a very simple way of telling how we're making patients better. And so those are called outcome measures. And so when we work on a new drug development, we have to go to the FDA, and we're in the process of doing this for a couple medications. And the FDA will say, Dr. Drolet, how do you know your patients are going to be better? You know, you may not cure it, we're not going to get rid of them, but how do we know this drug is really making a difference in their lives? And so with vascular malformations, it's really hard because each patient is so different. So your symptoms on your tongue, venous malformation, are going to be really different from your symptoms on your leg, venous malformation. And we can't do MRIs, you know, on everybody every 3 months. It's really expensive. It's probably not safe. So one of the things that we're working on, and this is where I think patient advocacy can be so huge, is starting to design patient-reported outcomes. And so those are essentially surveys where patients say, you know, before the medication, I had this much pain, I couldn't walk a block, I couldn't go to work, I didn't do a lot of social things, I didn't sleep well, I had depression. And there's formal surveys for those, but we just haven't really done those yet in a lot. We've done a little bit of it, but not quite to the science that we need to get an FDA approval. So it's kind of interesting. It's very basic clinical medicine, but we're just, you know, now trying to keep up with the cutting edge genetics and the drug development, so that we can develop these tools to make sure that the medications are making a difference for our patients, because that's what it's all about. I don't think we're going to cure it and get rid of it, but I think we can make people feel better. And the FDA doesn't like to approve drugs that make you feel better. They want to see a lab test or an MRI change.
It's quite a process.
Yeah, so that's where we're really going to probably be engaging a lot of the family advocacy groups to work on, you know, what's the most important thing to fix in patients with vascular anomalies, like across the different types of vascular anomalies. It's probably going to be pain, but also like how you function, and probably psychosocial, how you look, or stigmatization.
Okay. So we have like 23 people. Some are coming and going. And one of your former patients, Rodri, that's their name on Facebook, said, hi, Dr. Drolet, I have identical twins. One is affected, the other one is not. I spoke with you 2 years ago, and you helped us a lot as you gave us another view that we didn't have. So I'm not sure who they are, but that's a nice.
Hello.
She does have questions. Well, post them. You can post them here. Rebecca wants to know, how does a parent get genetic testing for their child's vascular birthmark?
Yeah, so that's a good question. The science is continuing to get better. The first thing you need to know is that genetic testing cannot be done on blood. So this is to Dr. Linda's point before, that even though birthmarks we're discovering are caused by changes in DNA genes. We consider them genetic. They aren't heritable in most cases. So in most cases, you don't inherit from your parents and you don't pass on to your kids. Rarely, there's a few, but the great majority you don't. And so what we found is the DNA changes are actually not in your blood. They're not in most of your cells. It's only in the cell that has the birthmark. So if it's on your leg, the DNA change would only be in the leg that has the vascular stain or the venous malformation. So very important that a blood test is not going to be helpful for our vascular anomaly patients, and even really good geneticists don't quite know this yet. So we still see folks getting blood tests, which are going to be negative. But what you need to do is get a tissue test. So you can take a small piece of the birthmark, and then usually we'll do skin because that's the easiest part to get. But if you've had a surgery before, the hospital always saves the tissue so they can go back on that tissue and do some genetic testing, and they extract the DNA from the birthmark, and that's the DNA we want to test. And then we test usually for a panel of about 130 genes in our research lab. And there are clinical labs that do testing. They usually test about 10 genes right now, and those are pretty good. And if you talk to your doctor, they can, perform the punch biopsy. You need to get insurance to approve it, and that is probably one of the biggest things that we struggle with because it's fairly expensive. But now that we're having some medications, we can say to the insurance company, this will make a difference because we will, change our management and potentially
less surgeries,
less surgeries, less MRIs, and potentially now some medications as well.
Great. So Rodri wrote back again and said her child had the MLT, but she has never had thrombocytopenia, although it's been more than 1.5 years without any blood tests, as her clinic is perfect. Do you have any registrations of children that have no thrombocytopenia and suddenly develop it? Is the outcome still thought that it gets better in time? Should we take care of something in special? Any other anomalies? So it's an MLT case, you're saying?
Yeah. So MLT is one of the rarest types of vascular anomalies. It is one we've actually tested to try to find the gene, and we have not yet found it, but we have several samples right now that we've sent to the NIH for kind of a specialized sequencing in our MLT cases. To your specific question, we have a registry of about 60 kids combined with the group at Boston with MLT, and maybe 5 or 6 of them really never had low platelets. So I actually really believe it can happen. I don't think it usually gets the right diagnosis because you don't have the low platelets, but the more we're, kind of being able to share cases among institutions, I think there's a lot of kids that have the pattern of MLT, and their skin biopsy looks like MLT, and then they just never had the changes in the platelets. I would say in general, kids tend to get better with age. So knock on wood, we really haven't seen kids that actually get worse with their platelets. So the fact that your daughter's doing really well and not had low platelets, the times that we worry about are those first 6 to 12 months of life. So you're a little bit out of the woods, which is great.
Well, and this is so interesting because we really are dealing with rare diseases with vascular anomalies. And so you get 3 or 4 cases and you think, okay, there's the profile. They all have thrombocytopenia. And then all of a sudden some cases pop out that don't, but we just never really had a large enough sample to see what it was. And so then that changes the dynamics. So hello to Margie and Eileen O'Connor. They're here. Eileen was our official photographer, and a number of people from the foundation are here. Alexander Exner is from Germany, and he said, my daughter was embolized last weekend in her right underarm, but now she can't cover her fingers. Now she can't maybe use her fingers. She was embolized with onyx. What happened? But I mean, it's kind of a hard thing.
Yeah, that's probably something that you want to talk to the physician, the treating physician. There are some nerves in the arm that, sometimes temporarily can get damaged, but that's a really important finding and something you'd want to talk to them pretty quickly about.
Yeah.
Yeah.
So this may be one of your other patients, Karen Grogenbrink. She says you are such a wonderful
Oh, that's
doctor.
nice.
And then there's follow-up. Rebecca wants to know, can you get a genetic test on a VM, venous malformation?
Yes. Venous malformations, I almost always we find the gene. There's two genes. One is called the TEK gene, and the other is PIK3CA gene. They're maybe half and half. So, but I would say that is one of the malformations where we have almost closed the book and the different genes that cause that.
Rodri wrote back again and said, by the way, they are in your MLT.
Yeah, great.
group, so that's really good. Mario said, are there drugs, not rapamycin, that can cure in the future for the tongue lesions? And I just want to say, like Dr. Coletti presented yesterday, that he's using ethanol, but we don't really have anybody that familiar with it in our country. But I can send you the information, Mario, for Dr. Coletti, because he has like a huge amount of success, and is, as well as Dr. Wayner has with the debulking of the tongue. So you can just send us an email, and we can put you in contact with them, and you can get at least a free opinion from them. Okay, so Sarah Caraballo says, are the genetic defects associated with VMs, meaning vascular malformations, at all related to the MTHFR gene? I call it the mother-father gene, gene mutation.
No. So that gene mutation is a pretty common gene mutation. It's something that we actually many years ago were really interested in looking at for hemangiomas, but I think once we got what we call a control group of babies that don't have hemangiomas, it didn't seem to be as important. Interestingly, all of the genes that we have found that cause vascular malformations have a very specific role, and they're all, even though they're different genes, they're very similar in that they are genes that are very critical in controlling the growth of cells, both the size, the migration, and the proliferation. And so it's sort of interesting, even though they're different genes, they all have the same function, which makes sense why so many different types of vascular malformations kind of look the same and act the same. So that's also very exciting, because it could be, when we start to look at medications, it could be as simple as 3 or 4 medications that could treat 30 different syndromes. So the genetics is actually simplifying some of the classification for us, and helping me understand, why one patient seemed to have more progression versus another, didn't have too many problems or too much progression.
So Jean Susher is just saying she's 63 and she was lucky enough to have her birthmark treated by you at Children's Hospital 10 years ago, 5 years ago. And she said she's so happy the technology has changed, and they can spare children emotional insecurity and low self-esteem. And that was something we're going to be focusing on this for our Perfect Vision 2020 year, is doing surveys for patients, for the families, the parents, and the patient on PTSD. And we're going to start, and I'm going to actually go and address the American Academy of Psychiatry and the psychological associations, and see if we can get some kind of protocol and guidelines or something, because we had a woman that came in that had 140 laser treatments, and she's not even 30 years old. And she said every time she sees a flashing light, she's like traumatized. So I think it's very important that we do this. Okay, let me click out of here because the questions aren't popping up. Are VM patients at risk of any other health issues, as some syndromes like KTS and stirred liver, I guess she's thinking?
So when I think about like in general approaching a patient that has a large vascular malformation, the things that I don't want to miss as a physician is the overgrowth. So making sure, especially in the lower legs, that there isn't a problem with the legs being different sizes. We also, want to make sure we don't see a lot of swelling and what we call venous congestion or venous hypertension, which can lead to some skin ulceration. And then the other big thing that we always think about, particularly if there's a lot of the venous component is blood clots in some of the larger veins. It doesn't happen for everybody, but that's sort of some of the concerns. So I think in general, those are the things that I watch out for. And then depending on where the vascular anomaly is, sometimes there's other tissues other than the skin and soft tissue and muscle and bone that could be affected. For example, in Sturge-Weber syndrome, when you have the vascular stain on your face, you can have abnormalities in the eye and the brain. So it's sort of a hard question to answer. In generally, most vascular malformations will affect the skin and soft tissue, and very rarely we'll see some internal complications. I don't know if I answered your question.
Yeah.
But yeah.
So Mary wants to know she was told her son would not be a good candidate for laser on the port wine because it's on his leg, and laser works best on the upper body. Is this true?
Yeah, so there's, I do think that there's certain parts of the body where the laser is more effective. In general, most of us would say the laser, if you use the right laser and at the right settings, we almost always get improvement. It's just a little bit slower on the hands and like forearms and as well as the legs. So yes, that's true. We tend to need a few more types of treatments, but it's not that it completely won't work. But a lot of times it's useful to do like a small test patch, and you kind of get an idea of just about how much change will happen, and then you as a parent can make a decision if it's sort of worth the worth the benefit of it.
Okay. So Sarah wants to know. She said her daughter's doctor told us that the venous malformation my 4-year-old has from her butt to the bottom of her foot are the only ones she has because she was born with them, and now she won't grow more. However, they won't grow, I think she means. We have a lot of people that are out from outside the U.S. However, I've seen other posts that they have had to start in another area, and then later in life they find they've had them in other areas as well. Are there different types of VMs that are distinguished genetically, i.e. some that spread and some that don't?
Yeah, so that's a really good question. The great majority, almost all venous malformations and vascular malformations, they really only affect the tissue that you can see at birth. And so when we talk about things getting worse or progressing, we usually are talking about that change happening within the tissue that started to have the abnormality. So if you think about it as, again, in the genetic basis, if that tissue, let's say on your cheek, has the genetic change, that's the area that's continued to grow and thicken, but it won't, we don't see the ability of the cells to kind of migrate to the other side of the face or to the other leg. There are very rare exceptions to this, and the blue rubber bleb, as we talked about earlier, may be one of the exceptions to this. But the great majority, it is sort of what you see at birth is the tissue that contains that change, and we don't see that change, migrating to other parts of the body.
Great. So our friend Rebecca Gallus from the CMTC Alliance is on, and she wants to know if you have an updated contact information for the overgrowth, undergrowth research study, because she wants to get that to her community. Yeah,
I was just talking to Dr. Tamburo yesterday about this. She's been very diligent in trying to get that started. I recently moved from Children's Hospital Wisconsin to the University of Wisconsin. It's a different institution. And so we just now got all the paperwork done to change the basis of the registry to be at the University of Wisconsin. And so we have that information hot off the press as of Friday. With the new contact information. So we'll get that up on our website and give it to Dr. Linda for sure. And I think Dr. Tamburo has it set to go up on your website. And this will be really useful, as we said, not only for the tissue, but we really want to start to study the patient-reported outcomes. What is it that's most important for you as families and for patients to fix with the medications, and then once we know that, we can design the surveys, and that's something I think anybody can participate in, and even from a distance. So I think this is where the social media will really be helpful.
And I think too, like we monitor 59 groups on Facebook, and I found there are so many that have still never been told they have an overgrowth syndrome. There were 2 patients that had really large legs, and they were told they were hemangiomas. And so I think we need a way too to get like a little query out there, and maybe I can work with Rebecca on it, to all the groups and say, if you have, and this is what overgrowth means, to contact Rebecca or you and determine if they fall in that category for that study, because they still don't know. So she said, thank you very much. What Sarah wrote again about was, she was wondering if her daughter who has the VM could some pop up like on her back or under her arm. And I don't know if she's saying because she's seeing something or she's just worried.
In general, no. Sometimes we'll see really small, like little specks pop up in different spots. And I always wonder, if those were there and just over time have shown up. But in general, Sarah, it's probably not something you need to be losing sleep over.
And it's interesting too, because of course you treat what you see.
Right.
And then, but who would ever think of doing a full body scan? Like Dr. Coletti was looking at he had brought an ultrasound. He was looking at a small venous malformation, but the understructure was so much bigger. So we don't know. Right. You just see as something small. So Kim Kraft says her daughter's 19 and has been treated by Dr. Richard Untitled. Great guy. Love him. Since she was 6 weeks old. We love him too. She goes through periods where it doesn't lighten at all with the laser, and it has darkened actually quite a bit. It's so frustrating for her. The port wine is on her face. She feels like she will have to have treatment forever. It's wonderful to see all the research you've been doing. And so do you have the Prima laser now?
I do.
Have you used it?
Yes.
And what are you seeing?
We've only had it for maybe 6 months. So it's a little hard to say. Certainly technically it's a lot easier to use, and you can, switch up the spot size and things like that. I work, one of my new partners at the University of Wisconsin is Dr. Lisa Arkin, who works a lot with Dr. Kelly from UC Irvine. And so
Dr. Kristen Kelly?
Dr. Kristen Kelly, yeah. So, again, I think what Dr. Arkin wants to do, and we just put in a big grant, so it's not on my mind, is think about combining laser treatment with medication. So now that we know the gene defects, maybe we can, try to kill some of those abnormal cells that can contain the mutation, and then use a medication after to prevent that darkening, because we know, we certainly know that's what happens even with or without the laser. Things get darker, and so right now I'm not sure we have a lot better options. Dr. Entai is amazing, and he's really very deep in the field of vascular anomalies and keeps up on things. But I would just tell your daughter, maybe be hopeful that there would be some changes, in the laser technology for improvement. And also, combining it with the medication, or maybe getting medication delivered through the laser, some things like that. There's a lot of interest in that as well.
I know Dr. Nelson's presentation yesterday, and he's been using the Prima laser for a few months. And he said it cuts treatment down by 50% because the spot size is so much bigger, and then it's faster. And he's seeing some really good results.
Yeah, it'll be interesting. I just feel like I haven't yet had my patients coming back. So Karen says she's 53. She has a large port wine stain on her left calf and ankle, and it's chronically larger than the right. I swell especially bad when I am sitting for long periods or standing for long periods. I tried the compression that were fitted for me, and they didn't help. What else can be done to control the swelling, and should I be concerned about blood clots? If it's just your ankle and foot, it's unlikely to have dangerous blood clots, because the danger to blood clots is that they will go in your lung, and so we as physicians worry most about blood clots in the upper thighs, even in the pelvic region, where it doesn't have to travel far to cause a lot of problems. At this point, I think compression is really important, elevation and compression. Sometimes when the compression doesn't work, it could be because the tissue has so much fluid in. So a lot of times if it's really swollen and been swollen for a lot of years, you put the compression on and it doesn't help that much and it's really uncomfortable. So I think I would consider, either starting with a lower amount of pressure so that it's more comfortable for you. The other thing that you might want to try is to look at see if you can find a physical therapist who does lymphatic massage. And sometimes that can be helpful, to do that for 2 or 3 weeks and really get a lot of the fluid out of the tissue that's been there for years, and then try the compression again. That would be my recommendation. It's hard to say without seeing it, though.
Yeah, Dr. Delphinian, who's our KTS expert, he tells a lot of the patients too to swim. He feels that that's like a natural way of stimulating circulation. So we encourage that, and we even came up with a suggestion for people who couldn't swim. Homedic sells that little tub spots, and that you can put in and keep the water cool and sit in it for a while. People are saying it's improving.
That's right. Because
So,
it's like the water puts pressure from the outside, so it's like a little mini massage. The water. That's a great point.
And Rebecca, she wanted to know too. She's been documenting her daughter's VM history and the whole psychosocial thing. As I said, for 2020, we're going to be doing a lot of work with the families on the psychosocial aspects of living with the vascular anomaly. And we were actually in the talking phases of doing some focus groups around the country using our global ambassadors who are around the country. So email me, Rebecca, because you would be great. I'm not sure if you're one of our global ambassadors, but we are going to be trying to do some focus groups to get some of this information about because we're finding out a lot of the families actually homeschool their kids because of the bullying, and some aren't getting the accessibility they need when they have Clipaltrenane. So we just want to document it. So please feel free to email me. And let's see what's next. So Kim Kraft says, thank you. We will talk to him about the medication. So somebody else asked about a medication, but I wasn't sure who it was. Let me go back here. Amy. Oh, who do I talk to about these drugs? I'm in West Arkansas. Should I talk to my dermatologist or PCP? Maybe it was when you were talking about with the
new medications. So right now, the only medication that we use to treat lymphatic and venous malformations is a medication called sirolimus or rapamycin. And we use that because it was already approved by the FDA and used for many different things. So we understood the side effects and the safety profile very well, and we could just prescribe it. The other medications are still in development. There's a couple of medications that we're starting to use in folks that are very sick from vascular malformations, mostly our arterial venous malformations. But if for swelling and pain, the sirolimus, it's helping quite a bit. It's not curing, but it can help quite a bit. And again, we know that this medication is a medication that would kind of tamp down some of the genetic changes that we see. It's not the perfect medication. We're trying to develop better ones, but this one works pretty well. So most vascular anomaly centers will have experience with using this medication. So just going to a center where there's a combination, usually the oncologists are the ones that are sort of in the vascular malformations world that use the medications even more than the dermatologists. So making sure that you have an oncologist that's a vascular anomaly specialist could help guide you with some of the medications. And even for the woman that was asking about the swollen foot, that might, if the swimming and the compression didn't really help, that could be the next step. And we've seen that. We haven't seen that the swelling gets that much better, but a lot less pain.
Well, and you answered the next question because they were asking about what is sirolimus. And Wendy Christensen Tamazian said to say
Oh
hello
my
to
gosh.
you,
Hello.
that you were a doctor, and she said Zoe says hello.
Hello. Oh my
so
gosh.
these are the kind of cool things that.
How old is Zoe now?
She'll pop on and say. So Dr. Drolet is got to get a flight back home. So we only have 6 minutes left, actually 5 minutes. So we'll be wrapping up early. Erin wants to know, so we only have 5 more minutes for questions. So Erin Lorene Wilkinson says, do you ever use rapamycin on your port wine stain patients?
So the rapamycin can come in an oral medication or a cream medication, and I would guess you're asking about the cream medication. I have used it a couple times, more in kids that have had a lot of swelling, so either swelling around their eyelid or lip swelling, and I don't know, I think it's helped a little bit. I have, over the last year, been thinking a lot about the science of developing medications that can get into the skin, and rapamycin is a very big molecule, and it doesn't penetrate the skin very well. So I think it's a good idea, but it's not quite the right thing. Again, it's sort of the thing that we have here and now. So many of us are using it until we can get something better. I do believe it's pretty safe. So especially in the cream. So if you think it's helping, I don't think it'll hurt. And I've seen it definitely help the swelling on the lips and some of the periocular swelling. I'm not sure it helps the color itself. But hopefully, again, we'll have something a little bit better. I'm not sure it's getting in the skin deep enough, just because it's a huge molecule and it just doesn't penetrate the skin very well.
Yeah, and I heard that there's one of the dermatologists out of Columbia Presbyterian told me they're working with a company on a delivery method.
Yeah.
Like almost a laser that helps to deliver the drug in a better way before you laser.
Yeah.
So one would deliver it, and then
Yeah.
So that would be cool.
Yeah, and there's different things that you can do, to enhance the medication getting through the skin, both from a chemistry standpoint, so make it smaller, or like micronized, or assisted, like Linda was talking about. You can make little holes with laser in the skin to deliver it. And so I would say there's more pharmaceutical industry interest in vascular anomalies over the last 3 years than I've ever seen. So lots of new companies starting up, trying to kind of deliver more medical treatments, which I think will be really great.
I think the next 5 years we're going to see major game changes.
Yeah, I think that's right.
I really do.
That's right.
So not to make you feel old, but Zoe is 13.
Oh my gosh.
And boy, I tell you, one of the patients that came yesterday said, Dr. Linda, we had a picture taken with you, and it was so long ago, my hair was black. And I'm like, that was like 1999. I'm like, wow. So anyways, oops, sorry. So we have 2 minutes left, and mostly everybody's saying thank you. A new one, Rebecca Helms LeBlanc said, if you have a VM and have no specialist in your area, should you establish with an oncologist? Who? Because her PCCP has no knowledge. So who should we go? Well, she can check with us. To the foundation, because we kind of know all of the treatment centers, and maybe she just doesn't know there's one in her area. I don't know where you're from, Rebecca, but you can message me, because I'd rather have her go to somebody that understands them.
That's right. And many of the centers are really used to having their patients live pretty far away, and so it could be that you visit that center, once a year, once every couple of years, and then we often find a local oncologist. Like, we started the sirolimus, we'd want to see you more than once a year, but then we partner with somebody in your town, and that's sort of the best of both worlds, because you'll have the expert and then someone local that can really deal with problems or questions and see you really quickly.
So Rebecca's just in Louisiana, so I think we can find somebody. I mean, she could even go to Arkansas. There's a couple places, so you can just email me, and we can give you a couple names of some specialists. Rebecca Streckfus said she sees Dr. Rosen, can't get any better. So we are going to wrap up your time, because I know you have to rush. And I want to thank you for
Yeah,
being
thank
here.
you.
And I
Thank you so
hope
much.
you will be with us on 10/10/2020 next year,
Okay.
October
Sounds
10th,
good.
for our
Yeah.
conference in New York. It's a whole different thing than the whole California vibe, but it's in the old Lenox Hill Hospital, you know, but it's just as wonderful. We really appreciate you and all of your time. So all of you, you can go back and rewatch this. I will be sharing it with all of the groups, especially because you do give a little information on how they can try to get the genetic testing, even though it might not be affordable. So thank you again. Safe travels. And bye, everybody. We will see you next month in November with Dr. Ann Comey doing our annual Sturge-Weber Syndrome Facebook Live. Take care.